So we'll have Catherine Kirkland up next, who is currently the Executive Director of the Association of Occupational and Environmental Clinics. I think I was mentioning I sit on the board there with Kathy, and this is where I first heard about the occupational health data from the NIOSH folks. And Dr. Kirkland's been with the AOEC since 1990 and has been the Executive Director since 1996. Her role in the, oh, sorry, it popped off on me when the screen came up. Her role in the AOEC has been to work with occupational environmental clinics like ourselves to provide education, outreach, and clinical services. And she's co-authored several articles on topics ranging from ethics to pediatric environmental concerns. She's a part-time instructor at George Washington University, Milken Institute School of Public Health and Health Services in Washington in environmental and occupational health. Dr. Kirkland's a member of the Delta Omega Honorary Society. She's spoken at a number of conferences with both US and abroad on topics related to environmental occupational health. Please welcome.
So as you can see by my title, I am definitely a little different than the previous two. But we've been working, the Association of Occupational Environmental Clinics, on trying to collect data on a number of things for a number of years. So who are we? Well, we're the Association of Occupational Environmental Clinics. We're a non-governmental, non-profit organization based in the US, which gives us a little more flexibility than the government agencies like NIOSH. And we have international members such as Ocow and a clinic in Germany. We're mainly US, but we're pretty good. We also have a multidisciplinary board of directors, which makes us a little different than many of the associations, clinical associations. We're not one specialty specific. We're not all physicians. We're not all nurses. And in fact, our bylaws, because we were a little physician heavy one year, we changed the bylaws to say we have to have at least one non-physician on the board at all times. So that makes us a little different than a lot of your associations. Now, one of the things that we wanted to do was to collect data to be able to inform what was going on. And so we, in 1991, started developing the AOEC database system, which was to be used by the AOEC clinics to collect data on occupational and environmental illnesses and injuries. And this also made us a little unique because we were dealing with occupational and environmental illnesses and injuries. And we started collecting the data from 1991 to the present. We have over 25,000 records, but unfortunately the EMR, EHR, whatever you want to call it, the electronic medical record or electronic health record, and in the US particularly, the Health Insurance Portability and Accessibility Act have caused issues with privacy and what physicians can and cannot report to a non-governmental organization, voluntarily report, and so forth. And so we've been working on that. Now, the purpose of the database was to figure out what specific conditions have been diagnosed as related to occupational or environmental exposures. In which occupations or industries are these diseases occurring? And again, we include the environmental. What exposures are causally related? And we have, because we limited this to our clinics who all have board certified occupational physicians, our standard was if they were 51% certain that the exposure was related to the diagnosis, then it could be entered. And what types of diagnoses have been associated with a particular exposure. Now, I'm really glad to see the ODH coming up because what we used in 1991, we started using the standard industrial classification and the standard occupational classification, which were updated on a regular basis. Kathy Hunting, who you will hear more about later, always found it interesting that epidemiologist was not in the occupational codes, but other people were. And so, you know, we use the NAICS system, but again, it's one of those that's constantly updated, and, you know, we didn't have it in the program that we were working on. So why create new exposure codes? Well, the problem we had is there are two commonly used systems for exposures, RTEX and CAS. And there's a problem in that it's very difficult for clinical use. It's easier for the industrial hygienists, but they're not the ones in the clinic with the patient trying to figure out what they've been exposed to. They may be coming in after the fact. The other problem is it can't be easily grouped. It doesn't include physical hazards. And as I said, just very difficult. The exposure code list was developed as a tool to help, and it's always had funding from NIOSH, which has been very helpful. Just to give you an idea of what the limitations are of RTEX and CAS, roughly half the exposures in the Aoec system have no CAS number, and there's even fewer with an RTEX number. So that makes it a little tricky for us to work with. So we developed this system. Well, the system was developed for us in 1994. Dr. Hunting is an epidemiologist. She's now retired, but she worked with the George Washington University, and she worked with Susan McDonald, a industrial hygienist, to come up with this system. And this paper will give you a full description of the system, but basically it was set up to be able to be grouped for epidemiology and to be able to be used by clinicians. So what we did was the purpose of it was that similar exposures could be grouped by chemical structure or other determinants. Physical hazards had to be included, and the codes had to allow for as much precise classification of exposures as possible, but it also had to be flexible enough for broad definitions. And that is when, it gets tricky. The jobs are bad enough. The exposures can be really difficult. The codes must allow designation of exposures when you just don't know what the causal agent is. The codes have to be easy to assign if the coder is not a chemist, toxicologist, or industrial hygienist, because a lot of times the database entry would be being input by an administrative person. And it must facilitate summary description. So we had to group them. So we group them by dusts, and there's certain chemicals, and then there's subchemicals. But to give you an idea of, why it has to be generalizable, not to cast aspersions on you industrial hygienists, Kimberly and Dorothy, but there were things like our industrial hygienists insisted that we have every kind of asbestos, the amosite, the tremolite, the cressetile, all have unique RTEC and CAS numbers, so we had to have a different exposure for them. But we also had asbestos not otherwise specified, and I can tell you that of the hundreds of asbestos cases that we've had input into the Aoec database, I have yet to see anything except asbestos not otherwise specified. So that's where we are. Physical hazards, typing, but also repetitive motion. Slips, trips, and falls, which we are all very familiar with and are very much part of the occupational illness and injury. So it's trying to come up with that. Now, originally, just to give you an idea of how far this has gone, and the exposure codes are available. I'll give you more information on this. But the database is out at aoecdata.org, and one of the reasons for having its own special website, not just being part of the Aoec website, is that it is what the US calls 508 compliant, so it meets the categories for being able to see it properly. But what there are 38 categories plus subcategories, and initially this was just 750 exposures. Now, as of this morning, there were over 2,000 entries in the system, and over 600 asthmagens listed, and 218 exposures reviewed as possible asthmagens that didn't meet the Aoec criteria, which I will get to later. Now, the trick is that I'm not an expert on using Excel, and I couldn't tell you how many of those were discrete numbers, exposure numbers. So when I get a Christopher back, I will do that. But things like, just to let you know the synonyms, so glyphosate, who's going to know what that is if you are not familiar with it? But Roundup, almost anybody can tell you what Roundup is. So again, that sort of thing with the synonyms. Keeping in mind, we're dealing with clinicians, we're dealing with people who aren't that good. So requests for additions to the exposure code, and we do make additions to the exposure codes on a regular basis. Their requests for additions are made to the Aoec office. Just because somebody says, hey, what about this particular exposure? Or, I've had a patient who's been exposed to this, and, have you done any research on it? Well, in addition to referring them to one of our member clinics to find out what somebody may know about this, I will make note of the exposure they're calling about and check with our experts as to whether or not we should add it to the database. If the clinics submit a database form with an exposure that's not currently on the list, I will again take it to our team and say, should this be added? The other changes that we make are new synonyms to make the searches easier for clinicians. We may have something out there and it has come up with a new generic sort of name, and so we will add the generic name to the list as a synonym so that people can actually find it. Those of you in Canada will also note that occasionally we've had to put something in with both the Canadian spelling and the US spelling. So those are considered synonyms too. There are 4 rules that, because we have different people working with this, we came up with 4 rules for the Aoec codes in addition to all the industrial hygiene information. 1, anything with a unique CAS number has to have a unique code. So even if they're very similar, if they've got a different CAS number, if they've got one, they get a code. We only list each synonym once. That one's been a bugaboo for me because I know that there are a number of things out there that people call by the same name that are different things, but I've been overruled. Every primary name has 1 code. So again, it's like the synonym too. Your primary name has 1 code. It can then be listed 6 times because it'll have 6 different synonyms. And every primary name is itself as a synonym. So as I previously mentioned, glyphosate will also be listed as glyphosate, and there'll be a second entry for it under the same code number that will say Roundup. Okay, so here is our screen. When you go out to it, this is what you will see. Now it's open source. Anybody can go out and take a look at it. It's searchable. You will note that that we've got a description of it. That's one tab. We've got the exposure code lookup. That's the tab you're looking at right now. And this is where it's searchable and downloadable. So you'll notice you could key in right here. You could key in Roundup. You could key in Toluene. You could key in typing. And then you click on search and it would display it. If you wanted to display all the hazards just to see what we've got out there, great. The other thing you can do is you can export the entire database to Excel. That was sort of the universal system that we thought would be appropriate for ease of use. And we also have some instructions on how to do this, but most people have been able to figure it out now. And it is important to have it be open source and downloadable so that anybody can look at it. Here, for example, just to use my title, are styrene and toluene. So you'll notice that we've got 4 entries for styrene, but it comes up with, styrene, and it's got styrene monomer, vinyl benzene, can't quite read that myself, cinnamine. I have to trust the industrial hygienist that this is correct. Okay, this is also, styrene is also a solvent. That, the asthmagen, here's the Artex numbers, here's the CAS numbers. And we have toluene, and you notice the same thing. Toluene has 4 synonyms. It's a solvent. It's not an asthmagen, so there's nothing in there. And it has Artex and CAS numbers. So, and this is what I see when I enter a code. So I started entering the codes back in, as soon as we developed the system, and I'm still doing it. It falls under other duties as assigned. Pepsigargan. Okay, it has a CAS number. It even has a synonym. I didn't put it in there. And we consult, before we add something, we consult with our clinical experts and an industrial hygienist. And just so that you know that Pepsigargan is a real thing, I didn't think so when I first saw it to be entering it in. And it took me a while to find the correct spelling because back in 1992, Google didn't have these sort of things. You couldn't search Google really easily. Life has become easier. So Thapsigargan is, just for your information, a phytochemical found in the roots and fruits of Mediterranean plants from a species that have been used for centuries in folk medicine to treat rheumatic pain, lung diseases, and female infertility. More recently, it was found to be a potent cytotoxin that can be used in some cancer chemotherapies, but is rarely used because of various issues. God help us if somebody decides that Thapsigargan is good for COVID, or we will be in what I used to tell my Girl Scout troop, which you're going to be in deep kimchi. You are going to be in pickled cabbage up to your ears if somebody decides this is the next cure. Okay, so just to give you a better idea, in 94, there was an effort to identify the solvents, the asthmagens, and the pesticides. And we very quickly figured out that was beyond our limited needs and funding. So we'd let the clinicians decide, use the EPA listing for pesticides. They've got a lot more staff and a lot more money. Identifying the solvents proved to be of low interest. That and the fact that things are identified as solvents that are also pesticides. Solvents run into various 38 categories. It was just not feasible for us to try and do that. And the designation of asthmagens, which was and is continuing to be of interest, was initially done using existing asthmagen lists, primarily by Jean-Luc Malot and Myra Chen Young. And the only problem with this was that they never described the formal criteria for how they determined what was an asthmagen and what wasn't. And that made life a little difficult because people would be going, well, where did you what criteria are you using? And so we developed our own criteria for what would be a protocol for identifying occupational asthmagens. In 2002, we started this, and Dr. William Beckett, who was in upstate New York at the time, did the initial protocol. It was ran through the Aoec board. It went through, all the clinics got to vote on it and make comments on it before it was finally adopted. We determined to only use occupational asthmagens because as a group that does occupational and environmental health, our members were not that expert on children. And there's a lot more nuances to children's asthma than we wanted to get into. So we decided we were going to leave the asthmagens strictly as occupational asthmagens, and the protocol deals with identifying occupational peer-reviewed literature that deals with occupational exposures. We stayed out of the environmental exposures on this one, just as a matter of convenience and making it the way it should be. And in 2006, Dr. Ken Rosenman at Michigan State University took over for Dr. Beckett as our resident expert on this, and his industrial hygienist, Mary Jean Riley, has been working with me since that time as well. Just to make everybody clear, well, we've had financing from NIOSH for the database itself. The asthmagen list, NIOSH has never provided any funding for that. They still fund a bit of upkeep and maintenance of the exposure codes, but they have nothing to do with the asthmagen designations. That is strictly an AOEC project for the convenience of our members. Okay, so how did we identify and change asthmagen designations? Well, the clinics reported diagnoses of asthma related to substances not listed as an asthmagen, so they may they may ask for us to determine whether it's an asthmagen or ask Dr. Rosenman to determine it, or I may bring it up to Dr. Rosenman because I've gotten something, a relationship in the database. And we get requests to reevaluate asthmagen designations, which may be made through the Aoec office, both to reevaluate whether something has been designated as an asthmagen or whether something has not been designated as an asthmagen. And currently, due to our funding, we fund Dr. Rosenman to spend the time to do roughly 10 to 25 exposures to review annually to determine if they meet the Aoec protocol as asthmagens. And one of the big things that Dr. Rosenman's been doing over the last 10, 15 years is going over the Myra Chen Young, Jean-Luc Malot list that we used initially, and making sure that what they listed as an asthmagen meets our criteria, our protocol. Now, just so that you're aware, just because something doesn't meet the Aoec criteria for being an asthmagen today doesn't mean it may not when more information, more studies are done, more papers are published. Our criteria is more exclusive than inclusive, but we're always open to looking at new papers that are being done. This also means, however, that we've actually had a couple of requests to evaluate asthmagen designations that manufacturers, various people thought shouldn't be listed as an asthmagen. And while most of them we say, nope, we've reevaluated it, and yes, it does still meet our criteria. It is still an asthmagen. We are going to keep it on our list. We have occasionally taken one off the list. And so that is, again, something that we, like I say, it's not a static list. And how the asthmagens are identified, because if you look at that page, you'll see that there's an A category that lists as an asthmagen, but then there's a separate column that says G is an exposure deemed to be generally accepted. R, capital RS, means it's been reviewed and it's a sensitizer. R, little r, is that it meets the criteria for RADS. R, little rs, indicates it's both a reactive airways disease and a sensitizer. And we've got 2 or 3 of those, not very many. And then an R is where we've reviewed it and it didn't meet the criteria as an asthmagen. And like I say, we have a number of those out on the thing. So here you can see that, it's the same sort of page. It's not very clear, but R, RS, RSG, and things like shrimp and crab are generally recognized as occupational asthmagens. I don't think anybody's going to argue with that one. At least we haven't had any arguments about that one. But it is interesting. And one of the things that happens with Dr. Rosenman, as it would with almost any of you, is we get a request for, looking at shrimp meal. And so he'll look at all the things that are, on the list that are in close to that. So, we've got 381, the 381. So he will go through and he'll review all the 381s that are potential asthmagens. The same thing here with your disease, your chemicals. So he would do like the 050s, there's a series of them. And these are our web pages. Now you can link to the aoecdata.org through our main webpage, aoec.org. The third one down there I put in just because this is the Ontario Ontario Clinics presentation. We have a project called the tongue's getting in the way. We have a project that we do every summer. This was our 19th summer this year, called the Occupational Health Internship Program. And you can see what the abbreviation is. We field probably a dozen calls a year from somebody, and I can almost immediately tell when they start asking about OHIP by the age and the accent that they're not interested in our student internship program. They want the Ontario Health Insurance Program. But apparently when you do a Google search, a lot of times our OHIP comes up before your OHIP. So one of the things that I do is in large print, I've got the your OHIP 800 number up here on my computer, on my bulletin board, so that I can tell them what the true 800 number is for what they're looking for. And I have to say that, you know, the stereotype of polite Canadians has been renewed, redeemed, refreshed, whatever you want to say. Almost none of them have any problem with the fact that they've called the wrong number, particularly since I can give them the right one. I did have one young man who kept insisting that I must be able to tell him about his health insurance, and I kept trying to explain to him that no, I couldn't. I knew nothing about it. And finally I said, look, I'm in Washington, D.C. I know nothing about your program. Here's where you have to call. And if you want to get in touch with me, this is the Aoec address and my email. During COVID, we started teleworking here at Aoec, and it's worked so well that we decided to save money on the rent. And but if you call the regular office number, we are indeed answering the phones. So with that, I will let it go. Stop sharing.
Thanks, Kathy. And I thanks for helping Ontario. I put in the window always, and it's always a little bit of a joke amongst us around the OHIP program. I do have a question from Lisa, but I did, Kathy, while you're thinking about it, while I read it, I hope you can tell the audience how people can use these exposure codes. Like, who can we shout out to, just so people might get, you know, a spark go off in their brains as to what this good work could be used for. So Lisa asks, some of the ingredients in the COVID-19 disinfectants, the quats we call them, the quaternary ammoniums, are listed as asthmagens in the Aoec database. Have you seen an increase in cases of asthma as a result of increased use of disinfectants over the last 18 months?
Our data isn't that recent. So, you know, we'd have to wait. The asthma people are definitely looking at it. You know, there's been a lot of concern about it, but we don't have any. Our data collection is behind, and the other thing is that people have been more concerned about everything else. So that just hasn't happened. As far as using it, we have a lot of, you know, the state data collection people in the U.S. use it. It is used, like I say, it's open source. You can just go on out to Google and use it, or you can download it. If you want to download it and put it, you know, incorporate it into your system, that's great. Our database system is set up so that every time I update the exposure codes, I just download the new exposure codes into the database program. Other clinics do the same thing. You know, Washington State uses it, New York uses it. You guys could use it. So yeah, and it well, we haven't been used. I see somebody said as an authoritative list. We actually at one, you know, it's changed a little the last administration, but it's still EPA has our list as a reference, and if it's listed on the Aoec list as an asthmagen, that's just a indicator that they should look at something more carefully. It's not that they take our word for it that it's an asthmagen, but they look at it, you know, it's a flag, not even a red flag, it's a yellow flag. But, you know, that is something that can be used. So yeah, that's, anybody is free to use it, free to contact me about if they have any questions, they have new exposures they want to put on it, let me know.
Excellent. Any other questions? You can feel free to raise a hand or write in the chat as you wish. So I hope you saw how we wove into framing the future a little bit around what work may look like, learning from our now, but strategic foresight, along with, yeah, you know what? These tools exist. We keep saying that we are under-reporting and under-recognizing occupational illness, but we have best practices here and in the States through NIOSH and through things like exposure code, through the Aoec, that we can tap into to help us collect this data and drive we're going to get into in the next few sessions, examining change. As Joel alluded to, kicking off Lung Month next week, we are going to talk about research and data a little bit. We are going to look at, I don't have it in front of me, collaborations. Oh, and I have another question in the chat. Have you found, what have you found? Oh boy.
Clusters.
Yeah,
I would have to go look at the database reports to figure out which ones we found were clusters. But I think there was, part of it was the initial, and it was partially our database and partially just our clinics picked up on the stone, the manufactured stone and silicosis. So that was kind of a group thing that, you know, when that started coming up. Trying to think if there was one other that I'm blanking. I was focused on doing this and I didn't review the reports, but I will go back and take a look.
Not at all, not at all. And yeah, and thanks for that, Dorothy, in terms of our, again, our cluster investigations are driving a lot of this prevention work. So it's what we find in our cluster investigations and through our use.
Diacetyl, that was it. Dorothy,
that's the other one.
Yep, that was the other one. Thank you, Dorothy.
Thanks. Usually that comes to me at 3 a.m. when that happens. So good for you. So yeah, just to note that our cluster investigations, and just a shout out to all of our interdisciplinary team at OCal that look at the investigations, the cluster investigations, people like Dorothy and you know, our really amazing interdisciplinary group of physicians, nurses, hygienists, ergonomists, and client service coordinators, and then this data drives our efforts, our prevention efforts as well, through things like the Off-Disease Action Plan or the Oculus strategy. So I hope you join us for the next coming 4 Fridays, kicking off Lung Month next Friday and the following Fridays in November. You can see a link in the chat window to register. Each week is different, and we'd also really appreciate completing a short survey, as we are, again, this comes to you at no charge, but it's super important for us to get feedback and know that you're with us in preventing occupational illness, and what we can do to make these sessions a little bit better for you, more pertinent. So very much appreciate taking a minute to fill out those surveys. And I'm not sure if there are any other questions. I think we have given you back a few minutes to your day, and hope to see you next Friday. So have a wonderful weekend, everyone, and stay well.